Bom dia. Hey, you see, I've been hanging out in Plateau. I've been exploring the local culture here in Santiago. And I'm beginning to feel a bit indigenous, yes. I'm told, by the way, everybody, that more of you this morning went down to the beach to walk the talk. I'm told that we went from 5 yesterday to 15 this morning. That sounds like exponential progress. Apparently people felt embarrassed by what I said yesterday. Good morning, everybody. I hope you feel you had a good day yesterday. You feel strong, you feel well nourished and ready for another wonderful day, day 2 of the second African Health Forum. We're all about universal health coverage, UHC. And this morning, we're going to focus on private sector engagement. Would you like to put another microphone here? Please do. Okay. On private sector engagement, we've got the princely total of 2 hours for this session. I'm going to use those 120 minutes wisely. You're going to hear very shortly from 3 representatives of the private sector who will be talking about real evidence-based action through the medium of what they themselves do in their business, how they engage with government, how they have meaningful and compliant access to try and change lives, save lives in a number of African countries, improving the availability of diagnostics, extending financial coverage and protection, and investing in vaccine manufacturing. There will be 3 TED-style talks, rapid fire. Then we'll have a wider panel. We'll have government representatives. We're delighted to have His Excellency, the Deputy Prime Minister of Cabo Verde, here with us this morning. Honorable Correa, please, we're delighted to see you this morning, sir. Delighted. And we also have Honorable Minister of Health, Nascimento, also with us here this morning. So we're delighted to see you as well. We'll have a round table up here, and then we will devote a lot of time to questions and answers from the delegates who will, I'm sure, be stimulated into action. You will ask questions, we will try and respond. But first, with her opening remarks, I'm delighted to welcome the Regional Director, Dr. Mweti, who is going to start off the day. Dr. Mweti, please, we would love to hear what you have to say this morning. Please, be polite and welcome Dr. Mweti. Mochidiso Mweti, the Regional Director of the WHO. So.
Thank you. Thank you, Henry. Oh, gosh. Your Excellency, Deputy Prime Minister, Honorable Minister of Health and Social Security of Cabo Verde, Honorable Ministers of Health and other sectors, distinguished participants, colleagues, friends, ladies and gentlemen. Good morning, bom dia, bonjour, and welcome to session 3 of this forum, where we are reflecting on how to make the partnership between the public and private sectors in health in Africa a reality, how to build on the discussions that have been going on since Kigali and at other fora to make this something that's actually moving, happening, concrete in countries. Honorable Ministers, before we begin, I've been asked by my staff to present this to you a bit dramatically. So, did you know that in 2015, our region lost $2.42 trillion, $2.42 international trillion dollars? That is evidence from a study that we are launching at this session. That's why I'm intervening at all at the start of this session. So this study is entitled A Heavy Burden, the Indirect Costs of Illness in Africa. And it estimates, using data from the Burden of Disease database, the loss in gross domestic product that member states in Africa experienced in 2015 as a result of illness and premature death. When one compares it to evidence from the Lancet Commission on Quality of Care, which estimated a loss of $6 trillion, that means that our region alone accounts for 42% of the global loss in GDP. And that is truly astounding. That's something that we need to note with concern and see what we can do to reverse this. However, the good news is that if we act collectively and we achieve our Sustainable Development Goal targets, this loss is reduced by almost 47%. So this is critical evidence that the health sector can use its engagement with ministries of finance, that we can use in our engagement with ministries of finance and other sectors on the urgent need for investing and action for health, because the cost of inaction is simply too high. We know that countries have made significant progress towards UHC, and those countries that have made progress are those that have relied heavily on public spending. In Africa, however, we know that public resources are limited. Countries are facing shortages in critical cadres of healthcare workers, and we also know that at least 400 million people have poor access to safe and affordable medicines. These weaknesses in the health systems undermine efforts to achieve universal health coverage. And many countries have pluralistic systems comprising the public and private sectors. The private sector, as we know, contributes to over half of service delivery in many of our countries in the region. Thus far, however, there's been very little engagement by governments to take advantage of the opportunities that the private sector provides in innovation for health, including networks that can be leveraged to extend service coverage and access to medicines and more. The existing gaps in service delivery and financial protection in the region show clearly that the public sector just can't do it alone. We need all hands on deck to achieve UHC. We've spoken a lot about the need for us to move to greater engagement of the private sector. However, we have to acknowledge that action has been slow. Why is this the case? What do we need to do to ensure that we move this agenda, we speed up, we accelerate in organizing this collective work? That is what we will be discussing at this session, bearing in mind the weight of the evidence that we are launching in this report. So, honorable ministers, with these few words, dear partners, I'd like to launch at this time the document entitled A Heavy Burden, the Indirect Costs of Illness in Africa. And I'm very glad to declare this session open. I wish you a very good day and good deliberations. Thank you very much.
So keep that figure in mind, 2.42 trillion, 40% of the global total. Let's build on that and set the scene in a bit more detail. Dr. Grace Kabanija is a health economist here at the WHO Afro, and she's going to come up next and prepare us for our series of TED Talks and the rest of this session. So, Dr. Grace Kabanija. And please be nice. Grace has worked so hard behind the scenes, and she's ready to take us to the next level.
Thank you, Henry. Thank you, Regional Director. Could we have the presentation loaded? So, honorable ministers, it is an honor and privilege for me to present to you a snapshot of some of the results and findings from this report that we are launching. And as the Regional Director has said, we've been listening to a lot of calls in different fora for evidence that can help the ministers of health, ministries of health engage better with ministries of finance, stating better the case for investment. And so this is an answer to that. The report helps to establish a link to ill health, between ill health and gross domestic product, building on a growing body of evidence. It presents country-specific data in terms of the loss in GDP for 2015. And so every country, instead of relying on figures at a global level, can see what that means for themselves. It also provides disaggregated evidence, as we shall see, and as said earlier, can enable us with dialogue with ministries of finance. Next slide, please. Next slide. And so we do know that the global annual SDG price tag that was estimated by UNCTAD in 2015 is that we will need at least $2.5 trillion to achieve the SDGs, okay? And colleagues in WHO estimated recently in 2016 that we will need annually at least $274 billion to achieve universal health coverage. But when you compare that with what we lose annually, at least as of 2015, $2.43 trillion in GDP, that is such a small price to pay for the loss that we experience. As earlier indicated, the Lancet Commission corroborates this evidence by showing that at a global level, in 130 low-middle-income countries, the loss in 2015 was $6 trillion. When we disaggregate this evidence by disease and condition, we see that the non-communicable diseases are driving to a large extent this loss in GDP by about 37% of the total loss. Communicable diseases that have been such a huge focus of our investment come up at about 36%. Maternal and neonatal conditions at about 12%. And when you look in terms of the life cost, who is causing this large loss in GDP from a human capital perspective, it's really around children of 0 to 4 years. Next slide, please. We have taken the liberty of also presenting the evidence because, again, this is where they congregate by regional economic communities, okay? And as we can see, in 2015, ECOWAS is the sub-region that actually had the hugest loss in productivity or in GDP. And this is driven largely by Nigeria because of the huge population, but also it is a big economy, okay? And then coming in second is the SADC sub-region. Next slide. When we model the data, taking into account the targets that we have set to achieve the SDGs by 2030, when we look, if we invest solely, this is solely on the health-related, the SDGs within 3.8, not taking into account the other health-related SDGs, we see that at a global level, the total savings are 47%, ranging from a high of 90% when we invest in TB and malaria to a low of 33%. And again, that is largely because we have been modest in our ambition for curtailing NCDs. Next slide. When we look at domestic resource mobilization, everyone here, I'm sure by now, is aware of the big conference that happened in Addis Ababa 2015 at the dawn of the SDG era. And in that conference, we resolved, one, to increase domestic resource mobilization largely through the Addis Tax Initiative, where we are saying we are going to improve tax administration, tax compliance, and so on and so forth. When we look at where we are currently as a region, basing on 2016 data that was the AU in conjunction with the OECD, the Organization of Economic Cooperation and Development, we see that Africa is still lagging behind other countries. And so even though on average we are above the 15% mark set by IMF at about 18% on average, we see that we are still lagging behind Latin America, which is at about 22.7%, and the OECD countries, which are at about 34.3%. And as you can see, there is a huge variation between countries in our ability to mobilize resources. That has impacts for how we invest in health, but also for health globally at the regional level, because from the experience in Ebola, we know that what happens in one country can very easily affect other countries. Next slide. This is just some evidence on where we are currently with spending on health. The black line in the first graph is the average rate of government spending by in the region. And we can see that low-income countries, which are the blue region, the blue line, sorry, have gradually decreased their spending in health, while the high-income countries in our region, that is only Seychelles, has steadily increased its expenditure in health. The low-middle-income countries and the upper-middle-income countries have fairly stagnated. The other graph shows you that for the bulk of the countries, about 25 in the region, there has been a deprioritization in health since the year 2000, meaning that as a proportion of the total budget, the share of health has steadily reduced in these countries, which is very worrying, a worrying trend for us. Next slide. This is just a few graphs showing you the relationship between the prioritization that governments are placing on health in the region versus the economic status. Many countries say, oh, as the economy grows, we shall spend more on health. And so then we ask ourselves, so is that a thing that we are seeing, that the richer the countries are, the greater they are spending on health? And as you can see from the first graph, this is not necessarily true. So you can see that for some countries that are have a higher GDP, so the lower scale is around GDP per capita. In the first graph, the y-axis is talking about the share of government spending out of total health expenditure. And as you can see, yes, generally speaking, we see some gradual increase as countries get richer, but that is not necessarily true for all the countries. And we also see that at the same income level, you have a huge variation in spending. Some countries spending much more as a share of total health spending than others. The other one is looking at the prioritization in the health budget, and it is a similar story. Very little relationship with the country's economic status. The size of the bubbles you see is, we weighted it by the populations in the country. So you can see that largely the smaller countries are the ones spending more, while the bigger countries, the biggest one there is Nigeria, of course, and the second largest one is DRC. The biggest ones are not spending as much as a share of their total spending, which means that for the bigger part of the population in the region, we are not prioritizing health as much, okay? Next slide. This is also just a snapshot really about where we are in terms of using innovative mechanisms, including health insurance, to mobilize resources. As we are talking about domestic resource mobilization, we are seeing a bit of an increase in health insurance from the national health insurance schemes coming up, although this is still small compared to total health spending, okay? And then we are also seeing, for many countries, a huge variation in the role that health insurance plays. Compulsory health insurance, this is through the national health insurance schemes. Sorry, please go back. And then the last one is the share of spending through private health insurance. And Chair, here I just want to say, to pause a little and reflect a little bit more. As you can see, we have Kenya, Zimbabwe, Namibia, Botswana, and South Africa as those countries that are relying a little more heavily on voluntary health insurance. But what is worrying us a little bit is that for these countries, we see that even though there is a huge proportion of the total spending coming through voluntary health insurance, it is only serving a small proportion of people. So in South Africa, it's only 16%. In Kenya, it is 1%. Similarly in Zimbabwe. And so even as we are thinking about the mix of services and the role that the private sector plays, we need to take this in mind. Where are they best placed to be? Next slide. We've talked a lot about efficiency. This is an assessment that we have done comparing spending in health per capita with the service coverage index that has been produced by World Bank and WHO as a measure of where we are in terms of increasing service access. As you can see, there is a huge variation. The top where you see 1, those are the best performing countries compared to the rest of the region. That does not mean that they are 100% efficient. It just means that relative to all the other countries, they are more efficient. And so you can see this lot of countries clustered towards my left, that for countries with similar spending, you have a huge variation in outcomes. And that shows you that there is room, a lot of room for us to increase in terms of our efficiency. Honorable Minister of Health, Cabo Verde, you will be pleased to know that you are the one on top there, number 1. Next slide. This is the last slide, and unfortunately it is not showing well. I don't know whether we can see the last figures down here. It was just showing us, even as we have resolved that we are now moving to we have made a renewed commitment in Astana on primary health care. How are we doing in terms of investing? Are we putting our money where our mouth is? And really, the key thing here is that when we look at the role of government in terms of overall spending on primary health care, government is still lagging behind the other sources. On average, it is just about 31%, but over 31% of total spending on overall spending for primary health care, which means that we really need to do a lot more. The good news, though, is that as a share of the government budget on health, most of the money, over 60%, is going to primary health care. Next slide. So these are issues for reflection. I won't speak to this very much. I just want to highlight that our spending in health is not keeping pace with the economic status and with our needs. We clearly need greater public spending, but also efficient spending. We also need to leverage other stakeholders and actors. And that is where now I bring in the discussion on the private sector. What can they do to help governments as we grapple with the issue of moving towards UHC? The last slide. So these are questions that Henry and the panelists will be reflecting on. What can the private sector do to support efforts to achieve UHC? What areas of the health value chain are they best suited to engage in? What bottlenecks are hindering this agenda? What can be done to unlock these bottlenecks? And what are the roles of the relative roles of the different actors? Ladies and gentlemen, I thank you. Next slide.
Thank you very much indeed, Grace. A huge amount of information to process, but it was very useful. So I'm going to lead the applause for you again and for Dr. Mweti for her opening remarks. That's great. Sets the scene superbly. A whole series of questions there. We're going to try, in as much as we can, to answer those questions. And first of all, we're going to hear from 3 members of the private sector who have those questions firmly in mind. And the first is, I met him yesterday. He's a global citizen, but he's also a British Kenyan. He's very passionate about this agenda, very passionate about meaningful, compliant access. He wants to work with governments. He's working at the moment with government of Kenya and Ethiopia on improving availability of diagnostics and equipment. Please welcome Chris Bonnet from GE Healthcare. Chris. I want some enthusiasm, so he presents and he will match your enthusiasm. Please welcome Chris Bonnet. Yes. Are you going to move around? You're going to stay there.
Okay. Bon dia, bonjour, good morning, habari gani, We can use many languages for everybody. I've been asked to do this in a little more informal way, so that's going to be quite difficult, stood behind the lectern, but I'm going to do my best. My name's Chris Bonnet. I'm the Managing Director for GE Healthcare Projects in Africa. Maybe we can go to the first slide, please. I think we've heard from WHO on some of the challenges that our continent faces. It's 11% of the world's population. We have 24% of the disease burden. Governments, private sector, don't tend to work well together. I'd like to show you two very clear examples of how not only is that possible, but what we've done and the outcome. I'm very excited to see the WHO report because I think we could perhaps even link our outcomes now to a fiscal benefit, and that's amazing. GE Healthcare is a technology company, but you can no longer simply provide equipment in an economy and a region such as Africa. It's 54 very, very different countries. And the issuing of equipment is simply not enough. We decided to take the journey 5 years ago to really build in Africa. So we're an African company. I'm a British Kenyan based in Nairobi. We have 700 people based on this continent, employed by GE Healthcare. Their role is to help our countries train, deliver equipment, deliver healthcare for our continent. We like to partner with ministries of health, NGOs, other private operators, WHO, and all other aspects of health provision in the continent. What do we do? Well, we're a manufacturer. We provide medical equipment. If you take a look at some of the areas on the right-hand side here, this will give you an indication of some of the breadth of our capability. And we're going to dig into two of these areas, one in Kenya and one in Ethiopia. So we're here on universal health coverage, and that starts with primary health care. Primary health care is for the most disadvantaged, the most rural in our countries, where we have the least healthcare workers. Our role as the private sector is to support and make that facility work. The simple provision of equipment is no longer enough for our continent. The provision of a working healthcare facility is what really, really matters. And that's what we as GE Healthcare try and provide for ministries, governments, etc. I'm going to pick on just two areas of how we think we're slightly different. Number one is we make very small ultrasound and monitors, but the delivery of those in a primary healthcare community is no longer enough. So we work with people like Farm Access, with other NGOs, and we provide the ability to provide training and education for 5 to 7 years, so that when we deliver a piece of equipment into a rural economy or equipment, it works, it has a service contract, it can work for the next 5 years. And that means that the investment in equipment is a good investment. Primary healthcare is also about then going up into all of the next levels of healthcare. So GE Healthcare provides primary healthcare facilities, primary healthcare equipment, but also up into very tertiary. So another example, again, I'm going to give you a Kenyan example. We've just designed, manufactured, produced, funded the very, very first full oncology center in East Africa. So ranging from primary to tertiary, we can cover all areas in between. Maybe we can go to the next slide, please. So what? That's not the next slide. That one. Thank you. Okay. Well, I mean, what does all this mean? We believe in measuring outcomes, not the simple delivery of equipment any longer. So we provide clinically relevant, affordable technology. We provide business model innovation to allow a company, a country, a government, or a ministry to fund the solution. We provide capital with our partners. We provide training and education, and we develop local partnerships to make this work locally. 700 people employed in Africa to make this work. I only have a few minutes. I could talk about this for hours, and I would bore you dreadfully if I did that. so I'm not going to do that. So all I want to do in the next few minutes is share with you 2 outcomes of 2 projects in our continent. And the first one is the Kenya Ministry of Health. Kenya is my home country, 55 million people. Imagine your country, and imagine if we could improve access to healthcare by 50% at 30% less cost for the patient. Well, that's what's been achieved in Kenya. In Kenya, a very forward-thinking Ministry of Health engaged us 5 years ago to upgrade health, not supply equipment. It was to upgrade health. And what we did was build a program of healthcare infrastructure modernization, working in rural hospitals. Some of them are old HIV clinics. How do you bring healthcare to the more rural populations and give better access to health? Well, that's what we did. Working through a 1 or 2 year program, we renovated 98 hospitals in 17 months. It's not been done before. I'll repeat that again. We renovated 98 hospitals in 17 months. We delivered over 700 pieces of equipment, and every year for 7 years, we train over 700 Kenyans. We've built a training institute in Nairobi, and it means that GE Healthcare is educating the next series of health professionals in radiology in Kenya. But we don't just train the doctors, we're training radiographers, radiologists, biomedical engineers to make infrastructure sustainable. By moving healthcare closer to the community and enabling access, we were able to monitor the progress of what we did. So I've already given you the numbers. 700 Kenyans are trained a year by Kenyans in local language, locally in Kenya. Each of the hospitals saw a 50% increase in patient access. 50%. The last number I'll leave with you is 30% reduction in cost to the patient. The patient no longer has to travel to Nairobi or one of the big 5 cities for a basic scan. These are all available at 2 hospitals within their local county. Imagine that in your country. The costs of this were equal to the operating budget that they were already paying. It's not my statement, but the gift of donations is the gift that keeps on taking. Equipment that is delivered without maintenance, without support, without training, is equipment that doesn't work, and doesn't work effectively. We manage these hospitals on behalf of the Kenyan Ministry of Health for 7 years. It is our responsibility, and we take that responsibility very seriously. I'm going to show you, so this is not tertiary. This is basic radiology and ultrasound in very, very small rural hospitals. Maybe we can go to the next slide, please. Everybody's seen hospitals. I've been in so many hospitals in our continent. We've taken old facilities, redesigned them, and we do this all ourselves. We realize that the capability in a rural environment to do this is sometimes lacking. So we step in. We step in to support and deliver a working healthcare facility. So very, very straightforward, a before and after picture. Designed by GE, funded by GE, equipment by GE, training by GE. Let's go to the next slide, please. I'm only going to touch on one thing here. There's one number which matters to all of us in this room. That's one of the reasons we're here in UHC, and that's 24% reduction in neonatal mortality. Imagine the same process that I've just described to you, which is the renovation of a facility with education and training. We train midwives, nurses to use ultrasound and look at the basics of health in a rural economy. We have solar-powered equipment that can really support rural healthcare. So can you imagine if you were able to increase access by 50% and reduce neonatal infant mortality by 24%? That's what we'd like to do. That's what partnering with GE Healthcare means. Last slide, please. I was asked to discuss what's the role of the private sector and what's the role of government. I have a very simplistic view in life. I believe that we have some expertise and the government has expertise. But the one thing that we'd ask the governments to do is to be an enabling force. Allow us to work. allow us to work compliantly, allow us to work in your country, we can bring a breadth of global experience to make healthcare work in your region. Last slide. That's it. I think my time is up. Thank you very much for listening.
Thank you very much indeed, Chris. I was going to say you were on time and on budget, but you went slightly over, but I mean, it was packed with information and very vividly presented. So some private sector people say, government, get out of the way. But he says, no, we want you to stay. But health ministers, we want you to be an enabling force. So work with us, don't get out of the way, but please do not block us for whatever reason, because we want to, yes, we want to make profit, we're businesses, but we want to deliver services to help the people. Okay, so now let's move from Chris Bonnet and GE Healthcare to Kwesi Boahene, who is the Director of Advocacy and Program Development at Farm Access, and he's going to be talking about extending financial coverage and protection. So please give him a warm round of applause. Let's say Akwaba to Kwesi Boahene, my kinsman from Accra, maybe Kumasi. Okay.
Both, actually. Both. Okay. Yeah. No, thank you very much, Henry. We've gathered here. My name is Kwesi Boahene from Farm Access. Henry did it. The focus of Farm Access is to leverage the capacity of the private sector to support government achieve an important goal, which is USC. We've gathered here this week to talk about the Africa that we want. And I think in order to achieve that, we need to continue the frank conversation. So my first point is that the main challenge facing a considerable number of African countries has nothing to do with lack of money. Actually, African countries, poor ones, they are even able to mobilize resources when they prioritize healthcare. Take the example of Ghana, not the most economically greatest of African countries, but Ghana in 2003 decided that it's going to finance health through its own resources. And since 2003, Ghana has been able to do that by instituting VAT. If you look at the Abuja Declaration, 2001, the countries which were able to meet the target 10 years after the declaration were not the biggest. Togo met the condition. Zambia, Niger, Rwanda, they met it because they prioritized healthcare. Actually, some of the biggest economies even reduced the funding for care. When we look at USC, according to estimates, if you want to cover everyone, it will cost us $60 to $90 per head. Take the extreme figure, 90. Most African countries, some of them, not most, but a considerable number of them, are spending that money. But even when you go to those countries, people do not have a decent care. Why is it so? Because they haven't instituted inclusive health financing mechanisms. Point 2, still about frank discussions. The rise and fall of USC is related to the rise and fall of the private sector. And it's just based on facts, because 50% of the services, and even in some countries more, are delivered by the private sector. So, we can go on and on and on, and most governments have recognized that. And within Farm Access, what we do is actually to leverage that capacity to support governments. I believe, and that's the company that I work for, we believe that the solution in transforming some of these challenges lies in mobile technology. And I'm really not talking about the fancy smartphones I'm talking about the old, good old phones, the feature phones. 80% or more of Africans have access to some kind of mobile communication. And you've seen how that has transformed the financial landscape in Kenya. You know, Farm Access, together with CarePay, that is a social enterprise in Kenya, and Safaricom, which is the Vodafone of Kenya, we partnered together and in 2015 developed a technology platform called MTIBA. And what MTIBA does is that it mobilizes resources to finance healthcare for people who are not in a position to pay for care. So MTIBA connects. Can I have the next slide, please? MTIBA actually connects different players. It connects the individual seeking care by giving that individual what we call mobile health wallet. And that, so you see, before we developed MTIBA, this is a classic situation in African country, the one on the left. So many players, everybody trying to reach the same person. We developed MTIBA, and because the individual can pool financing from different sources, whether it's insurance, it's performance-based financing, it's subsidy for the poor. You see that on the right side, we have a bit of transparency in financing of care. What MTIBA also does, please the next slide. Yeah, so what MTIBA also does is that it gives the insurer, you know, whether it's a national health insurance agency or it's a private insurance agency, it gives the insurer the possibility to administer health insurance through the mobile health wallet at a very reduced cost, because we are talking about people who do not have the means to buy health insurance at a high cost, and we deliver that to them. An important aspect of what MTIBA does is what we have here. So we have the provider. What MTIBA does is that it provides real-time data to the provider so that the provider will be able to ensure improved care. The provider, through the ability to do that, is able to improve health outcomes. And of course, one of the most fundamental issues that we have in Africa is how do you get the cost down? And you can only get the cost down if you have insights into how the costs are made. And MTIBA provides that all on this feature phone. You know, we can demonstrate it after this session when time allows. In addition to this, we also provide capital. So we have an initiative called Medical Credit Fund, which provides capital to small and medium-sized private facilities to enable them to deliver quality of care. We can provide capital from as little as $1,000, depending on the size, to $2.5 million, depending on what you get. And we partner with local banks to do that. You know, through all these efforts, we have reached over 2,000 clinics, and every month, about 2 million people are able to access quality of care through this initiative. Technology is there, and we need to embrace it. Whether you are small country, small organization, big organization, we all need to embrace the technology that we have. You know, I'm from Ghana, and I will end with this proverb. You know, in Ghana, we say that when you think that you are small to effect change, and you believe that, what it shows is that you've never spent a night with the mosquito. The mosquito is very small, but can cause considerable effect. So I'm employing all of you, small, big, let's get together and embrace the technology to deliver on USC. Thank you very much.
Just a Ghanaian to ask you to think like a mosquito. Kwesi Boahene from Farm Access, thank you very much indeed. And now the final one of our TED-style presentations, and this really will be a TED-style one, i.e. incorporating dynamic kinetic movement here on stage. Our third and final speaker in this part is the Chief Commercial Officer of the BioVac Institute, which is of course from South Africa. She is Ms. Sandra Lambert, and she's going to talk about investing in vaccine manufacturing. Please be very generous in your bienvenue, in your welcome to Sandra Lambert. Keep the clapping going, please, until she's in the middle of the stage. Sandra, over to you.
Henry.
Yes.
Good morning, bon dia, and bonjour, everybody. Thank you very much for inviting me to speak here today. I'm very grateful for this opportunity. So I'm quite happy in a way that I'm speaking last, because I'm not exactly working for a public or a private sector company. The BioVac Institute is actually a public-private partnership, and we are quite proud of that fact. So just to start with a few numbers, when you work in the world of vaccines, we get on a weekly basis an update on all the different outbreaks that are happening globally. It's very scary, but it kind of puts things into perspective. And yesterday, I actually received the updated numbers for the Afro-WHO monitoring. And there are 4 specific numbers I want to share with you. So it's 3, 12, 13, and 6. So in the last 3 months, so the first 3 months of 2019, we've had 12 different countries in Africa that have had outbreaks. 13 of them were caused by viruses. So within 12 countries, there were 13 virus outbreaks. And of these 13, 6 of these viruses have vaccines available. So that just goes to show that to this day, and we are in the 21st century, we still do not have viruses, even those that have vaccines available, under control. And globally, currently, we are experiencing a huge shortage with vaccines. So it becomes even more important for us to actually consider how we as a continent can become totally self-sufficient from a vaccine manufacturing perspective. So this is where BioVac comes in. So about 15 years ago, the South African government realized that from an Africa perspective, we do not have sufficient vaccine manufacturing on our continent. And scarier is that in the southern hemisphere of the continent, say in the SADC region, there were no vaccine manufacturers. For this reason, it was decided by the South African government to actually try and start vaccine manufacturing in South Africa. And what happened was the South African government partnered with a private funder, and the BioVac Institute was born. The South African government has quite a significant share within the BioVac consortium, but the only contribution that the government actually made to growing BioVac, or to putting it into place, was that they allowed BioVac to have the complete authority of the EPI supply for the country. So BioVac is completely responsible for supplying all the vaccines into the EPI sector for South Africa's public sector. The private sector, while the private side of the business, the responsibility of the private arm is to specifically make sure that we have sufficient funding. So all of the risk that was needed financially to be able to grow BioVac, establish the physical and the human resource capacity for the company, was all done through the private side of the business. Another important thing to note is that BioVac is run as a private company. So government in this instance does not get involved in the day-to-day running of the company. The exco of the company actually make the decisions, and BioVac really is run as an independent company. This kind of model allowed BioVac to actually start to slowly grow the capacity. It's taken a long time, but the one key learning that was very important into the way that BioVac is being run currently is that we implemented what is known as a backward strategy. In most pharma companies or vaccine manufacturers globally, all the companies normally start with research as step one. So the research will be basically what really gets the company up and going. With BioVac, we were not at a point where we could even consider doing research of vaccines. It takes about 10 years, best case scenario, to put a vaccine on the market. So we had to find another way to actually look at it. So we started from the end in mind. So we actually started as a company just doing distribution of vaccines to the public sector. Then we started slowly with labeling and packaging of vaccines at the site in Cape Town. They haven't put my slide up yet, so I can't show you the site yet. But then from there, we then started to do technology transfers with big pharma companies. So we've managed to secure 2 technology transfers with 2 major multinationals to actually learn the skills to be able to do the formulation, filling, and packing of those vaccines at the BioVac site in Cape Town. And now we are at a point where we've actually gone to the beginning where most companies do start. We've now actually started doing research as a pharmaceutical vaccine biological company. So currently BioVac is doing, well, we are now starting to do research on a novel conjugated GBS vaccine. We do have funding through big global partners, so PATH and other partners have been very generous and I think forward-thinking, if you want to actually consider their mindset, to realize that if they start to help an Africa company develop a vaccine in Africa completely, we would be able to actually have this vaccine for our continent. GBS is a disease that currently affects mainly neonates, and it is passed from mother to child. We do have a high incidence of GBS in Africa, and a lot of the cases could actually be prevented with vaccination. So the whole aim now is for us to actually develop this vaccine and research it, test it, and market it, commercialize it in Africa. Now, from that perspective, we can say that BioVac has been successful. It is growing. We've had a wonderful progress from starting as a public-private partnership and having the support we did to be able to get to where we are now. But from now, where do we go? And I think this is something that we really need to consider. Vaccine manufacturing for Africa is critical. One of the things we need to consider as Africans is that if tomorrow there is a pandemic, we would at this stage probably be the last continent to get a vaccine. Globally, currently, there aren't enough vaccines. If we suddenly have a major pandemic and the entire world needs a vaccine, if we cannot manufacture a vaccine from beginning to end on our continent for our populations, we are in trouble. How can the governments of Africa help? One of the ways that we can help is in situations like BioVac's situation and other vaccine manufacturers, and I think right now we have about 4 on African continent, 1 in the southern hemisphere, the other 3 in the northern. We need the governments in Africa to really help support local manufacturing. We need to have the kind of setting where Turkey and Brazil have been wonderful examples, that if, let's say, there is a local manufacturer on the continent, they actually commit to procuring and to buying first from their local manufacturer. So in cases where we have very few manufacturing sites in the continent, it becomes a responsibility for all of us, for the entire continent, to make sure that these sites are manageable and in the long term can be 100% self-sustainable. So the one message I'd like to leave with you today is please consider vaccines made in Africa for Africans by Africans. Thank you.
One more time for Sandra Lambert, please. Thank you very much. And Sandra, would you kindly take your seat? I'd also like to invite the other rapid-fire speakers to take their seats as well, Christopher Bonnet and Kwesi Buahene. And then we have a panel joining you as well, led by the Honourable Minister for Finance and the Deputy Prime Minister, indeed, of Cabo Verde, the Honourable Olavo Avelino Garcia Correa. Please, Honourable, do come up on stage. We would also like to invite Ms. Ruzvizo Tokozili Ruzvido, the Director of the African Center for Gender and Social Development at UNECA, Mr. Greg Perry, and Greg is the Assistant Director General, and this is a big title, the International Federation of Pharmaceutical Manufacturers and Associations, and Dr. Amit Thacker is also going to join us, and he is the CEO of Africa Health Business. I know he's got a lot of other titles, Amit. I know you wear them well on your head. And of course, I'm going to join you all as well. So please put your hands together for our panel. And of course, an interpretation is available, okay? And we hope we won't have the issues we had yesterday. So we had 3 presentations, which gave us a lot of information, and they gave us a sense of how, in practical terms, private sector partners are working with government and other agencies to bring healthcare equipment and greater access to people who most need it. I want to hear from our colleagues on stage, first of all, what they made of what they heard. You don't have to respond to every single presentation, but you might want to reflect on what you heard. So, Honourable Deputy Prime Minister Correa, would you like to let us know what you made of those words? Is that the kind of example that you would be looking for, that maybe you could work with here in Cabo Verde?
Let me speak Portuguese. Muito bom dia a todos.
So, Honourable Minister will speak in Portuguese,
Yes.
as we are here in Cabo Verde, of course.
Thank you very much. Translate is working?
Yes, I think it's working, yes. English, I think, is on, it's English on 5, is it? 6. English is on 6, and French is on?
2.
English is on 2, sorry. French is on 3, and Portuguese 1. Okay. Very good, okay. I think we're set. Everybody ready? Honourable Minister, please.
Okay. Muito obrigado pela oportunidade.
This opportunity and for organizing this conference in Cape Verde. Health is an essential thing for all our countries, because at the end of the day, we all want to be happy. And without health, it's not possible to be happy. Sub-Saharan Africa, unfortunately, has 11% of the population of the world, but accounts for 24% of the burden of disease in terms of financial and human costs. This is a heavy responsibility, but also a major challenge that we as African leaders have to overcome. We cannot overcome these challenges if we continue to do more or less the same thing, if we continue to look at health as a public service that is limited, if we cannot involve other partners, particularly the private sector,
so that we can come up with better solutions to attain health for all and universal health coverage. In Cabo Verde, we're spending more on health. 10% of state budget every year goes into health, and it's growing. And 3.6% of the GDP goes into it. But we do have a lot of challenges, and they can only be overcome if we can open up the health sector to the private sector. And for the people, what is the most important thing is not whether the service is public or private, but that it is of quality. So we need to open it up, because then with the private sector, they can provide a quality service, and with proper oversight, the level of service will be good. But both the public and private sector can come together to provide better quality for the peoples. We cannot continue to count with public investment to overcome the challenges of health. We need to open up the sector to the private sector. We need to show confidence in the private sector, because in any case, we're all Cape Verdeans, public and private sector, and what we want is better health for all our peoples. All of us, public and private, have the same responsibility in terms of creating the conditions to provide quality health services to all the citizens. So we are going to change things. We are going to open up the legal framework and also invite foreign investment to ensure quality service for all Cape Verdeans. Everybody is invited to participate in coming up with better health services for all the citizens of Cape Verde. Thank you.
Deputy Prime Minister, thank you very much indeed. I'm conscious of time, so I'm going to ask all my panelists their comments so that we can get some feedback and some questions from our colleagues in the room. So Dr. Thokozile Rusvidzo, from your point of view, I mean, you're uniquely poised, really, as a champion of gender and social development at UNECA, based in Addis Ababa, I think. That's right, isn't it? Given what you've heard, what are additional and new areas that governments can explore in engaging the private sector to achieve UHC? Because you've seen the willingness from our colleagues here, but they need partners, enablers, not blockers.
Thank you, Henry, and I'm not going to respond directly to your question, but indirectly to your question. I think what is key for me is this event is taking place after two major events that took place in Addis Ababa on the backdrops of the African Union Summit, where heads of states participated and committed to financing, committed to supporting the private sector and making the regulatory framework positive for the private sector. However, as our theme says, let's move beyond rhetoric. And I think that's what we are asking member states, to start looking at governments, especially how do we move beyond rhetoric. And I think critically, in a report that we produced and we shared at one of these two events, which we produced with WHO, UNAIDS, GBC Health, and the Aliko Dangote Foundation, the question the private sector was asking is, what is in it for us? And listening to the three presentations that we had this morning, I think for me it was fascinating. Fascinating in that it's a win-win situation for all. In Chris' presentation, I would have loved to hear what the benefits are for his company in terms of hard currency. How much are they making? Obviously, government is benefiting. The community is benefiting. So there is a win-win-win situation for government, for communities, and the private sector. And I think we need to look at the benefits for the private sector in hard currency. As my executive secretary said in one of the events, health is good business. If you are in health, there's good business. And I'm not saying it's just good business for the private sector, but it's good business for everybody. Let's also look at what the benefits are. Let's break them down, the benefits for government. Let's look at the benefits for community as well, so that no one is left behind. It's a win-win situation, and it encourages the private sector to invest in healthcare. And I think this is more critical because our report came out, and I have a few copies out there of the executive summary. I would invite everybody to pick one. Africa has a 66 billion gap in health financing. And I think from what Grace presented, clearly we need the private sector in there. But if we are to bring in the private sector, they have to look at what are the benefits for them. Let me just go on to Sandra's presentation, which I thought important. Important right now when Africa has just signed on, we need about 22 countries to sign on and ratify before the African Continental Free Trade Area comes into force. But it can only work if we industrialize on the continent. And what is in it for the health sector? And basically that's what Sandra was talking about. Manufacturing vaccines. You manufacture vaccine. You trade or you export vaccines across the whole continent, and the ACFTA provides the opportunities for that to happen. And what does that mean for health? It means there is access to vaccines. Africa imports 70% of its pharmaceutical needs. Can you imagine if we produced on the continent what it would mean for women and children, because that's basically where I'm coming from. What it would mean for women and children if they had access to cheaper drugs, to cheaper equipment that, basically we are importing, except for the exciting work that I had from Chris. So we need not to leave anyone behind. We all look at the cost benefit of investing in health. Thank you.
Thank you very much indeed, Dr. Rusvidzo. Wonderful. Great feedback there. Dr. Amit Taka, I know you're a private sector man, but you have a public sector heart as well, I think, having met you a couple of times. And I'm just wondering, given what you've heard, what are the key things we need to do as a matter of urgency to make greater effective involvement of the private sector a reality? Because we want to move beyond the rhetoric, as we've said in this particular session.
Yeah, I think this is one more event that's building up the cusp of transformation that we are at in the health sector in Africa. I haven't seen a time in my 25 years career that we are seeing the wave of change. The public-private partnerships and collaboration is at its highest. The commitments from the head of states, it's at the highest. The leadership from the ministers of health that I've seen in Africa is at its best. We have the finest leaders in the public sector who now understand what the two things that need to change healthcare in this continent was discussed this morning. And those two things, Henry, are partnership and leadership. Let me just say what my take-home message was. I believe that the morning presentation showed us we need to spend more for healthcare. We don't just need more money for healthcare, but we need more healthcare for the money. That's critical for all of us sitting here. Efficiency from the ministries of health across the entire continent is non-negotiable, and leadership is by the head of state and the Minister for Health. We must produce more with what we receive. The second I have also seen in leadership is that the private sector must do better in understanding how the public sector works, and vice versa. And we must build trust. The model of trust between public and private is a two-way street that we in the industry must understand how the public sector works, and we have to do the best in engaging them regularly. So I congratulate WHO and organizers and the leaders to make such an event happen. The second part, quickly, I want to talk about is partnership. And what I heard from all the presenters today, that it's not always about the bottom line. The private sector in health is talking about double bottom line. It's not always about the share prices and profit. It's making an impact in society that's going to have a long-term effect on the 1.2 billion that are sitting there. So many private sector organizations have the public heart matter that they are engaging in on a regular basis. So this is where the blend between public and private happens. Without partnership, it won't proceed. We need to ask each one of us, what role are we playing in the partnership? Are we a multiplier of partnerships? Or are we an addition? Or are we a division? Or a subtraction? What symbol do you represent for the partnership in Africa? Thank you.
Dr. Thakur, thank you very much indeed for that. Wonderful. And then let's hear from Greg Perry. Now, I'm just thinking what the attitude of your organization, you have a lot of members. People often look at the pharma industry with great suspicion and don't embrace it as a friend. They think the drugs are too expensive, they have to be made, manufactured in Africa. I think one of our speakers yesterday said 80% of the drugs that we use on the continent are imported. What's your response to what you've heard in terms of the presentations, and how do we take things forward?
Thanks. The first thing I'd like to say is I just endorse everything that's just been said by the previous panelists. I think it's very important. I think we should look at the way that we're working like a triangle, in which we have health workers, the public sector, and the private sector. I put health workers there because they can work for both private and public sector, and they're key in delivering what is in the middle, which is the patients. So we must have this triangular approach. We must build up on the trust. And we must be able to work in partnerships. I am repeating things, but I want to enforce those things. So from our particular sector, I'd like to emphasize a couple of things, also picking up on what Chris said. Chris said, you know, their company is not just an equipment building company. It's much more than it has to be. And the innovative pharmaceutical sector takes the same approach. So a lot of companies are not just manufacturing and delivering the product. They're actually involved in working with various partners in the supply chain, in the distribution chain, in order to provide the road that enables the treatment to get to the patient. And it's building those health systems and supply chain and distribution chain works which are absolutely essential to get the treatments to the patients. This industry can't work on its own. It can't. It needs everything around it in order to deliver those products. And in innovative products, and the more innovative products that become available, the more complicated they will be, particularly, for example, in NCDs in cancer, where you'll need a lot of support working with healthcare professionals and special machinery in order to do that. So we need to be able to work in partnership in order to deliver that. And that's why the role of the public sector must be principally one of a regulatory authority and establishing ethics, establishing governance. All of that is essential in the healthcare system, but also being that enabler that Chris had mentioned. Without the enabler, the industry cannot deliver. So I also want to make a quote, because this comes to the other point about the role of the industry and the pharmaceutical industry, where in fact I was on the plane and I mentioned to a delegate that was coming, I was from the pharmaceutical industry representing it. He was from an NGO and he said, oh, we're from the other sides. And I said, no, we're not from the other sides. We've got to be thinking, you know, we have one objective, which is the patient. Now, of course, industry is profit-based. And that's why it's interesting to hear terms like, you know, health is...
That's right, the doctor wants you to make money, you know.
Sorry?
The big question you actually said, didn't you, that you want to make sure that it's win-win, yes, and that the private sector do need to be able to turn a profit in order to keep going in this.
Exactly, that's why health, you know, health is healthy business, is a good term. And I want to quote a US trade union from the 19th century, and it's very important. He said, the worst crime of a company to its workforce is not to run on a profit. And that comes from a trade unionist. Obviously what he's thinking about, a profitable industry is one good for the workforce. A profitable private sector is one which is important, I think, for all of the community. Now, very specifically, because you asked me a question I wanted you to, is around the issue of our drug delivery, our drug pricing, affordability. Now, when you have such a large amount in NCDs, for example, that is taken up in the cost of medicines, that has to be looked at wider than that. That is because medicines, unfortunately, seem to be the first port of call for a lot of patients, when really it should be looking at prevention, you should be looking at surgery, there should be more costs on diagnosis and treatment. So the medicine amount and the budget is probably far higher than it should be overall, because there isn't enough expenditure in that which is around it. So that needs to be looked at. The second, of course, is the amount of money that's coming out of pocket in Africa and in certain other areas as well. That's because we need to build up insurance systems. And the third thing, which I must emphasize and is important, is how much, particularly on this continent, that when we look at the price of medicine, is actually taken up in the distribution channel, from wholesalers to pharmacists. And we must be able to work together to try and address and see how we can make the provision of medicines affordable and available for all on the continent.
All right. Thank you very much indeed. That's a panel. You've done very well so far. Let's transfer the energy from here to here. Yes. Because I now want to hear what you have to say. Not at great length. You have to land quickly. You remember yesterday? You have to land smoothly. So, let's see who has a question for the panel. Yes, Madame, in the second. And you have a microphone on your table, don't you, I think? Is that right? Oh, okay, you've got one there. Okay, please tell us who you are and what your question is. Okay, while you're struggling with the microphone, I need to go to the honourable ministers first. You've got your microphone is working. Okay, go.
I'm sorry, the microphone is inaudible. We can, the interpreters cannot hear the microphone.
I think we need to return the micro before we have to bring it back. Yes.
Finally,
yes! Eureka!
I'm Dr. Margaret Agama Anyete from the African Union Commission, and thank you to all the panelists. My question goes directly to Sandra. In 2016, heads of state and government approved the establishment of the Fund for the African Pharmaceutical Industry. Since then, the Commission has been working with stakeholders and partners, including the Africa Development Bank and the Afrixian Bank. My question to you is, what is it that African farmer needs to do to make it attractive to attract funding if the fund is established? Thank you.
Thank you very much, Sandra. Direct question. Let's go for a direct answer. What does African farmer need to do?
So thank you for the question. I think, you know, it's a bit of a complex question to ask because, you know, when you look at it from obviously the company's perspective. So in our case, I mean, I can't speak for pharmaceuticals, I speak for vaccines. I think what really needs to happen is that, you know, there needs to be a very good case to the fund to be able to show the benefits of long-term investment. It's good to know that, you know, this fund has been started and there's been discussions around it. I can tell you from a BioVac Institute perspective, we currently are trying to raise funding specifically to continue the research on the vaccine that we're working with. And we're actually finding it difficult to find partners on the African continent.
What is the problem?
We actually don't know who we can go to, who we can speak to. We're actually not sure of who to approach in Africa that would be willing to support funding to see this vaccine come to market. So I think it's good to know, and actually yesterday as well I've heard of other
Sorry, 1 second, Sandra. We're not hearing you because there's some weird interference, some alien somewhere. I'm not quite sure what's happening. Can the technicians sort out that problem, please? Okay, Sandra, you need to land. Okay, go for it.
Fine. And yesterday I actually heard of other organizations that would be very interested in supporting us as opposed to the globals like the Gates Foundation and PATH. And I think it would really be great if there was some kind of communication between the funding mechanisms that are being put in place for healthcare on the continent, and the companies that are actually establishing manufacturing in Africa, and some way of getting them together to actually support the growth of manufacturing locally on the continent with the funding on continent, so we can keep it all in-house.
Greg, do you have anything to add to that? What does African Pharma need to do? Do you have any thoughts on that?
No, by the way, I'm very happy to see that this could actually take place in South Africa. And I think all I can say is that I've worked before, very quickly, because I have to land quickly, I realize that.
Yes.
I've worked before in the HIV area. I ran the medicines patent pool, and that was involved in licensing agreements between innovative and generic companies. So there is a willingness where needed and where the conditions are right for innovative companies to license with local companies. Of course, as I said, there requires a whole series of conditions like that. But I have a feeling this sort of thing will develop now much more quickly than it has done in the past.
Thank you very much. I see we have honorable ministers and representatives of ministries from a range of countries. We have Uganda, we have, is that Namibia? Guinea, Equatorial Guinea, Togo, Seychelles, etc. And I can see the honorable minister from Namibia wants to make a comment or a question, please. And also then Uganda.
My name is Ben Nangombe. I'm not the minister. I'm the permanent secretary in the Ministry of Health and Social Services.
Yes.
My question goes to Chris. He mentioned that the intervention in Kenya led to the improvement of health outcomes by 50% at 30% of the cost to the patient. In many of our countries, public health care is basically free. A patient comes to a health facility. In the case of Namibia, they pay 70 US cents to get the health passport. From there, they get the care, whether it is a primary health facility, it's a district health facility, it's a referral health facility. They don't pay anything else. What I would be interested in to know from Chris is the improvement of the health outcomes. At what saving is it to the Ministry of Health?
Okay.
Thank you very much.
So the permanent secretary in Namibia wants cost savings. Chris, can you deliver with your model?
Well, we've just seen that we're not spending enough, so cost savings are difficult. I think if we take Namibia as an example, you know, and it's difficult to draw, I need to be careful about how we talk about Namibia. Look, in Kenya, what we did is we brought healthcare closer to the community. So things like travel time, time to wait, tertiary referrals were very, very low. So for example, in Windhoek, you have 2 tertiary hospitals. They are quite full, because the feeder hospitals to them from everywhere from Gobabis to the south just literally have very long referral chains. If you put healthcare, imaging equipment, ultrasound, basic equipment, these people don't have to come to Oshkati, don't have to come to Windhoek, they could be treated locally. And that is a massive cost saving, because you are currently paying for ambulances to take people all over the place. The families are currently traveling all over Namibia, and it's a big country. You know, really healthcare in Namibia is in 5 main places: the north, Windhoek, maybe a little bit in the south, and on the probably west coast. So what about everybody else? You know, 60% of the population of Namibia is in the north, and the healthcare there is fantastic, but needs more in the rural and local communities. So we know Namibia very well. We'd be delighted to come, and we'd be delighted to show you what we can do in Namibia.
I think we've got a willing partnership here, and I'm glad to see it's been realized live on this stage. Excellent. Honorable Minister from Uganda, or Permanent Secretary, I'm not sure which.
No, Minister from Uganda.
Yes, thank you very much.
Thank you very much, moderator, and I want to thank the panelists but I also want to thank WHO for that detailed presentation that you made. And I want to acknowledge that universal health coverage is something that all our governments must actually focus on. The commitments have already been made. We need to look at investments in the human resources for health, which remains a key challenge on the African continent. We need to look at equipments, we need to look at infrastructure as a whole. My country, Uganda, definitely we have a policy where we are saying that we need to ensure that at least within a 5-kilometer radius, there is a health facility for everyone to get to. But we must look at the other factors. Now, this takes me to the question that I wanted to ask. In the morning presentation, we were given statistics from the various countries, the economic status and spending on health from the different countries. And when I looked at the WHO, I think the recommended spending, the presentation was that countries that had earlier invested heavily in health were actually reducing their expenditure. But what we are not being told is where is the shift? Why this reduction in the expenditure? And this is what I wanted to know. Because when we are talking about investing in health, it's not just money into the health sector. We all know that there are certain factors outside the health sector. Those are the social determinants of health, where governments need to invest. And once you invest in those other social determinants for health, you may not need to put a lot of money into the health sector. Mm-hmm. When you look at issues of education, you look at the environmental issues, you look at the poverty, bring your people out of poverty, you don't need necessarily to put money into the health sector. Mm-hmm. You look at issues like hygiene and sanitation, and yesterday somebody said, universal health coverage is health for all, but also all for health. So if we have empowered our people to be responsible for their health, and Professor Maswa, the gentleman who mentioned that health is actually made at home and only repaired in the health facilities. If we look at that and focus on that we have empowered our communities to focus on the health, do we need to put a lot of money in the health sector?
Thank you very much, Honourable Minister. Thank you very much indeed. I'm not sure if Dr. Mwete, maybe later on, if you have any concluding remarks, you may want to reflect on what Honourable Minister from Uganda has said. But I want to get another question in, and let's have a look. Lady right there, with your left hand up, please keep it up, and get the microphone over to you. Let's get the microphone over to you. Oh, there's somebody with the microphone over. Okay, because it's taking a long time, you have the microphone. Let's go with you now. Yes? What's going on? Okay. Sometimes I think I should just take the microphone and do it myself. Come on. Yes.
Good morning, everyone. I am Cornelia Pereira, sociologist, a Cabo Verdean, and the president of an association called the Anti-Cancer Association. I don't know if I'm sorry, we are having trouble understanding what she is saying. I would like to congratulate the speakers for the interventions they made. I would like to greet the Minister of Finances and the Deputy Prime Minister and the other members of this panel. I don't know how many minutes I will have. So I would like to say that the Anti-Cancer Association was born in 2007 due to, I'm sorry, we can't hear what she's saying, including doctors who dealt with cancer-related issues, and they thought it was the right moment to bring the issue of cancer to society. And the association has been working on major cancer issues, especially breast cancer, colon cancer, and prostate cancer. We have been working mainly alongside the longer, more...
The association needs to give us a question so we can put it to the panel, please.
Ok. Então, eu gostaria de colocar...
So I would like to ask a question, which is, how can we establish partnerships between NGOs and peer associations, and so that we can share the wealth of knowledge and experience that other NGOs and associations may have in this area? And also, we have major constraints because we work with isolated communities. So how can we, what can we do for there to be a partnership so that we can ensure that mammograms, for example, which are essential examinations to these isolated communities, and also vaccination, the issue of vaccination is also an important issue.
Madam, please, we're going to have to stop because other people want to speak and we really don't have the time. I'm going to have to put that question, I think, possibly to Chris. Your question was about associations partly, but also about availability of equipment like mammograms. Okay, please.
So, thank you for your question,
Thank you.
Madam. Let me answer it very simply. I don't think it's just an NGO thing. I think invite the private sector. There are many of us that can come and help. We can design cancer centers. We work on clinical solutions. We can work on anything from mammography to full oncology centers. We showed you what we did in Kenya. I believe that many of us could do that in Cabo Verde as well. Invite us. Let's have a dialogue.
Greg, you want to say them?
Sort of saying the same thing as Chris, but I'm very happy to speak with you afterwards if it would help.
Thank you very much indeed. Please, can I implore, do not talk for too long. We will lose your question. We will lose your question and I'll have to stop you. Okay, where's the microphone at the moment?
It's here, right here.
Okay.
Right here.
Go for it.
Hello?
Yeah.
I'm here. I'm right here.
I'm looking, oh yeah. It's the speaker, go, yes.
Great panelists. My name is Dr. Joan Bansing. I'm with Merck Vaccines, and I lead our public health partnership efforts there. We are the manufacturers of the Ebola vaccine, and my question is to Chris Bennett. You gave a very impressive, talk about what you're doing in Kenya and other countries. So I'd just like to understand, tell me a little bit more about your business model, because as we think about engaging government, sometimes it's damned if you do and damned if you don't. So it will really be very helpful for you to drill down more into that business model, because we want to be a part of the solution, and sometimes it feels like the governments are not necessarily being enabled.
The static is so terrible, we didn't hear everything you said. Not your fault, but I will try. I heard you. You wanted Chris to drill down and give a little bit more detail about his business model. I'm going to say, Chris, you won't going to have time to go into your business model. If you have your elevator, if you elevator pitch on the business model, you've got 30 seconds, okay?
Okay. All governments have a capital budget and an operating budget. They rarely work together. We bring together a full equipment solution with everything we're doing for 7 years in one payment for government. I'll happily discuss that with anybody afterwards. The noise is terrible. I'm sorry, we can barely hear each other.
Sorry about that. Technicians, if you can do something about the static and the feedback, it would really, really help this session. Now, I don't know where the microphones are. I'm depending on the ushers. Okay, at the back there.
Good morning, everyone. My question is directly to Chris Bennett. I would just like to say, as the Deputy Minister said, we got 10% of world national budget for health in Cape Verde, which seems to be a lot. So my question is, Chris Bennett, we can compare Cape Verde with Kenya financially.
Okay, I've got a suggestion. I have a suggestion. If we have technicians, find us a mic. Hello? So wait a minute. A microphone that works. What I want is people to come here and speak from here with a microphone that works, okay? This is the only way we're going to do this. So technicians, technicians establish the best microphone and let people form a line. Yeah, form a line here and then use the best microphone, because the room is not working. It's just not working. So technicians, the best microphone, and then everybody who wants to speak, form a line on this side and a line on that side. So 2 good microphones, one here and one there, form a queue, and that's the only way it's going to work, because all over the place, it's just not working, okay? So technicians, 2 good microphones, one here with the usher and one there, and form a line if you want to speak or ask a question. Do you understand me?
Yes.
Is that clear? So ushers with the best microphones, please.
Hello?
Come to the front, come to the front. It's the only way it's going to work. So microphone A, microphone B, and a line behind, and a line behind. Okay, it's the only way. Okay, so all people who have switched on their microphones, apart from the roving ones, switch your microphones off so that it will stop the feedback. Okay, where's the lady in the front, yes? Okay, you're going to come to the front, yeah? Okay.
Good morning, everyone, again. I'm Vanusa Brazão, so I'm a physiotherapist and professor at the University Jean Piaget. I was just mentioned that the Deputy Prime Minister mentioned about the 10% of our budget, Cape Verdean budget, go to health.
Yes.
So my question goes again to Chris Barnett, because we can compare Cape Verdean reality financially with Kenya. So, hello, my question is, how could Cape Verde, how could us, with all our financial partnership with the GE company, where we can improve our health quality and increase our access for the community, how can we afford that?
Okay.
Thank you.
Thank you very much. Chris, can you respond quickly?
Yeah, sure. So firstly, you're already doing a fantastic job in terms of the Africa rankings. Secondly, GE is not about size. It's about the right scale for the right country. We've done 98 hospitals, but the Ethiopia example I showed you was 10 clinics. Invite us, allow us to work with government. We will find a solution that fits Cabo Verde. It will fit the technology, it will fit the budget.
Excellent. Thank you very much. Okay, let's go to this side. Microphone? Yes, you're this side.
Good morning. My name is Obi. I'm from the Commonwealth Secretariat in London. My question directly is to Amit. Now, in today's globalized world, we have companies operating in Africa who are French-founded, German-based, Dubai-incorporated, New York-listed, and serving the African continent. Now, we have a population that is very price-sensitive. My direct question now is, how do we unlock the potential for African firms to be competitive on the continent and offer very good prices in relation to globalized firms who also serve the same population? Thank you.
Okay, so unlocking the potential of the African industry, yes.
Yeah, I think the SME question is great. African corporates are a good answer for affordability in healthcare. We don't always have to wait for multinationals to provide solutions. So like vaccines, which is made in Africa, by Africa, for Africa, is the way to go. We are our own problems in a way, because we tend to compete rather than collaborate. Time is now right for African companies to collaborate, to offer solutions through SME platforms, organized private sector solutions, and that is why we have formed the Africa Healthcare Federation to fuel up investments in healthcare that are homegrown in every country. So I'm happy to talk to you later on this. Thank you.
Wonderful. Okay, next question.
Abdelaziz from the Arab Bank for Economic Development in Africa.
Say that again, say.
My name is Oussama Ben Arab Bank for Economic Development in Africa. We have been financed health infrastructure in Africa for more than 4 decades, ranging from basic health centers to big teaching hospitals. And I want to hear from private sector representatives what would be the advantages of a public-private partnership scheme in a sector that is not generating cash inflows like health, in comparing with the classic procurement chain financed by development banks and other financial resources.
So you're looking at the unpopular areas that are not cash generating. Okay. So who's going to answer that? Maybe Kwesi, what do you think?
First of all, I can challenge the assumption a bit, if you don't mind. So we started the Medical Credit Fund, which provides loans to small clinics. When we started, the banks, so we work in Ghana, Nigeria, Kenya, Tanzania, and other countries. The banks, the local banks, didn't want to get into this business because, the reasons, some of the reasons you gave, and they also said it's too risky. We don't want to be there because we lose our money, it's no cash, barter, and all those things. And we challenged them, So what we did actually is provide capacity to the clinics working in there because we are dealing with private clinics. So we work with them, and what I could tell you now is that the portfolio that we have, the loans for health SMEs, in all these 4 countries, that portfolio is the best performing portfolio for the banks because they saw it. The other part of it is that, of course, in certain societies where people don't have money, it's a bit challenging. And that's why the partnership with the state is important. So I've seen in certain parts of Nigeria where the public and private sector are working in the area of insurance, and they are extending payments, finances to these communities, which actually supports the private healthcare facilities to be in that space. So I think the solution to that will be, the partnership between the 2 states, the 2 entities, and then put more emphasis on innovative financing, which will create the money that they need to do that business.
Can I just add one point, Henry? I agree with you in a way because we are not as powerful as infrastructure in PPPs and economics. Health has been a laggard. And this is why our federation is developing great pipeline for opportunities if you look at PPP opportunities in healthcare in Africa, they are very low and very few. But if you look at the number of roads, bridges, and agriculture projects, those have big dollar value. It is up to us, with the people who are sitting here, to frame opportunities in healthcare that will be attractive for both public and private, which creates the win-win model that we heard earlier. Thanks.
Before we go to the next question, Deputy Prime Minister Kore, I would like to ask you what you're able to do. You're a Minister of Finance here in Cabo Verde, to assist to become an enabler of companies here that are struggling to be more competitive and to be more attractive as partners or as potential receivers of investment from other maybe larger companies or partners like some of the companies we see here. What are you able to do, Minister, as an enabler here in Cabo Verde for companies?
Muito obrigado mais uma vez.
Thank you. We need to consult with regard to the under 5 children. Whoever is responsible for doing things needs to make changes in our countries. And to do this, that means that we cannot continue to do as before. Because if we continue, it will take generations because before we have health systems that can provide quality. And it's okay for the private sector to invest, but we need to have the right and business climate and the possibility of oversight so that we can guarantee quality service, whether it's from the private or public sector. The public is not necessarily better than the private sector. The important thing is that the service should be of quality. And so we need to develop templates of quality. And we also need to have systems to ensure that funding, which used to be public in the past, that is being used to build roads and ports and all that, should also be channeled to ensure health for all, so that the future of our countries will be dependent on the quality of human resources. And this means that we have the right quality of health. We also need to have qualified human resources. So we in Cape Verde want to create conditions to ensure that the private sector can invest in health. We also want to open up the public sector to ensure that the private sector is involved. All these people want anyway is quality service. They don't care whether it's public or private. They just want the service to be quality services. So anything that we can do to ensure that we have quality service is what we need to do to make it happen. So we are open. We are going to promote support for the enterprises, for oversight, and support for the international sector that may wish to invest in Cape Verde. We don't have money to invest in roads and airports and stuff. What we want to do in Cape Verde is to build hospitals. We want to be able to manage them, and we want to have PPP in a win-win situation so that the public will be better served. And this is possible. And this is what we want to see happen. Everybody is invited, the private sector, the international world, to come and invest.
Thank you very much indeed. Okay, we're on this side. Let's get our next question.
Yes, hello. I'm Lamia from Sanofi Pasteur.
Amina, is it?
Lamia.
Lamia, okay.
Do you hear me well? Yeah. So my question is for the entire panel, and maybe more particularly to Sandra. So how far the African countries are today facilitating the use of vaccines that are produced locally in Africa in terms of regulatory advantages, facilitating the registration of the vaccine produced locally, or trade and marketing of the vaccine. So if we take the example of the BioVac Institute, if tomorrow you need to export the vaccine produced in South Africa to the SADC, for instance, how far will it be easy or difficult? Thank you.
Okay, thank you very much. Sandra.
Thank you for the question. Currently, BioVac has some vaccines that we are locally packaging or filling or labeling, and we have the marketing authorization with the partners that actually make the API in other countries. Those dossiers that we have registered in South Africa, we are in the process of registering in the countries around us. But as you know, with the registration process, we need funding. You know, we obviously have to budget for it as a company and make sure that we have the dossiers ready for submission in the different countries. What we are doing on an ad hoc basis right now is that when we do get requests from neighboring countries for vaccines that we can supply, we are actually going ahead and submitting those prices. So we currently do supply some vaccines to Namibia. We also supply the anti-venoms to the Namibian public sector. So when the tenders are available in the country, they actually send us the tender documentation. We do supply Swaziland with their vaccines currently. We are trying to get some supplies into Angola, and I'm looking at the minister because I hope to speak to her afterwards. But we are very actively trying to also let our neighboring countries know that the vaccines that we work with currently are WHO pre-qualified. They are from reputable partners that are supplying us the vaccines. we can actually supply them at very good prices. And unfortunately, we get the requests when our countries do not have access to the global vaccines because of shortages. But I think that's also our job as BioVac, to make sure the continent knows about us and what we can actually do from a supply vaccine perspective for our neighbors.
Excellent. Okay. Thokozile, you wanted to make a contribution?
Yes, just a quick response on, how then the vaccines can be moved across the different countries. There are various trade agreements that exist. For example, SADC, within the context of COMESA, have agreements that facilitate movement of goods and services. So this is an opportunity. Unfortunately, they are very limited. There's limited production of vaccines on the continent. So it's important that the private sector produces more. The opportunities to trade across the whole Africa now has been opened by the Africa Free Trade Continental Agreement. It provides the opportunity for that to happen.
Wonderful. Thank you very much. Okay, we've still got some people who want to ask questions from here and here. We've got just all together, 10 minutes left. It means your question has to be hard and tight, direct, and then same with the answers. Okay.
Thank you. My name is Dennis Lee. I'm one of the 30 innovators.
From the challenge?
Yeah, yes. Innovation Challenge. I come from Uganda and I'm a legislator and a member of Pan-African Network on Illicit Financial Flows. I'm aware I have constrained capacity of Africans to deliver on universal healthcare coverage.
Mr. Innovator, you've used 15 of your 30 seconds by preamble. You have to
I wanted to know, is PPP being proposed by the private sector the kind of model we need for universal access care in Africa? Is it a model that incorporates tax concessions, tax agreements, preferential ones that you prefer, or you like something which excludes those two components, which are key drivers of...
All right, so you've got a concern about the kind of PPP. I mean, the private sector is huge in many different parts, but I'm going to go to Amit to see if you have a brief response on that.
I think what we're proposing is the full 6-step range, from outsourcing to leasing to build, operate, transfer, any of those. So private sector is open for any part of working with government to make health better for the people living in the country. It could be basic or it could be sophisticated, and that's the answer.
There are so many different models. Kwesi.
I think it also depends on the context. And so you've got to look at, specifically if I will talk about Nigeria, that you have a lot of public healthcare facilities that are not functioning. And then some states have come to the decision that they need to partner with the private sector. So private sector takes that, manages it, and deliver care. If you take Ghana, for example, and that's very innovative. So they have the Christian Health Association of Ghana, huge network of private religious hospitals. They are about, they constitute about 6% of the healthcare facilities in the country, but they deliver 30% of the services. So what the government has done is, and these facilities are mostly in the villages. So what the government has done is pay the salaries of some doctors and nurses. They are working for the private sector, but they see the need that they're contributing to a national goal. So I think we have to look into some of the
so many different kinds of models. It's not just one thing. Gentleman there, yes.
Thank you. My name is Dr. Mwai Makoka. I work with the World Council of Churches. And I'm just been pleased that for once somebody has mentioned the Christian Health Association of Ghana. I think the reality in Africa is that universal health coverage will not be achieved without having the faith-based sector on board. Because firstly, there's a service delivery component in terms of clinical services, but also pharmaceutical supply chain. There is also the issue of community mobilization and also ideology. And so there is a great need to have the faith sector on board and to
You're making that point, or is there a question? Because I think we probably would agree with that point. Is there a question coming? If not, we're going to move to the next person.
Okay, so I will leave it there, that the faith sector is critical for universal health coverage, so that is everybody on board. Thank you.
Landed. Okay, yes.
Parler en français?
Yep.
Oui. Je m'appelle professeur Boulahi, directeur de l'Institut national de recherche en santé publique à Mauritanie. Donc ma question, l'expérience du Kenya, est-ce que cette expérience peut être généralisée à d'autres?
It be replicated in other countries. We have a problem with maintenance of equipment. We buy equipment, but we don't find people locally who can maintain them. Can the private sector not, in some form of partnership, have a database available for countries who may need such services? Because we are looking for such people. We have the money to pay them, but we don't find the individuals or the companies that can offer the spare parts and ensure continuous maintenance. Secondly, just a second question, very quickly. Have they used telemedicine to gain access to specialists? For instance, if you need a radiologist, a pathologist or a pathologist in the rural areas, how do you have specialists everywhere, or do you use telemedicine to reach them? Thank you.
Telemedicine is big here in Cabo Verde, but what about the model? Yeah.
So I'll answer the second question first. All 98 hospitals in Kenya are interconnected digitally, so it doesn't matter where there's a radiologist in one area, images can be sent across Kenya. That's the second question. On the first one, it's more challenging. Yes, part of our solution is we do an assessment in country, we'll look at the equipment, whether we can replace it, refurbish it, repair it, or manage it for 5 years. So I can't answer the question directly from Mauritania, but again, invite us to come, willingness and a government that's willing to support, and you will have the full support of the private sector.
Excellent. Le monsieur from Mauritanie said, nous avons l'argent à payer.
C'est possible.
Il faut les experts. Bon.
Pas de problème.
Voilà. Okay, monsieur. Yes.
Thank you very much. I would like to extend my thanks to the panelists. My name is Dr. Molukoso from the Republic of Liberia, Ministry of Agriculture. I have a question to the manufacturer of vaccine. In Africa, it has been noticed that we are so glued to our colonial powers or whatsoever. When something is labeled made in the UK, made in the US, people are fighting to get it. How are you managing to move our Africans to move to buying African goods than buying goods that came from their colonial powers?
All right, that's a good question.
Going to deal with
okay,
that?
so Sandra, so made in South Africa. Do people recoil when they see this brand, or do they think, yes, that means it's good quality, we can work with it, it's African, let's work with it? What are you getting by way of response?
So thank you for the question. I think it definitely is, a mindset. From a South Africa perspective, BioVac has an extremely good reputation, especially with vaccines. To manufacture vaccines wherever you are in the world, you have to meet a very, very specific criteria. Anything involving biologics is a very complex process. So we have a GMP-approved site, and I think that really on its own does create the reputation. We also do have multinational partners, as I said in my talk. We have done 2 technology transfers with 2 major global vaccine manufacturers. And I think all of that has gained BioVac a very reputable reputation, especially in South Africa. We don't seem to have any concerns or questions from any neighboring countries at this stage that request vaccines from us where they actually doubt the quality of the vaccines. And one of the things that we have done is we have tried as much as possible to bring different leaders of different organizations, countries, to actually visit the site in Cape Town. It really is a pity. Apparently my slide was very data heavy, so I couldn't put it up. But we have a world-class manufacturing vaccine site in the African continent.
Excellent. Thank you very much. Final question. Microphone, yes.
Thank you for the 30 seconds, Mr. Bonsu. My name is Robert Ejakun from the African Risk Capacity. Shocking to hear the data presented by WHO, and even more heartbreaking is the fact that we still import 70 to 80% of our drugs. My question to the ECA and perhaps WHO and African Union is, what is our 5-year, 10-year, 20-year strategy to increase production of medicines on the continent? And what assurances are we giving the private sector that if they do make investments in this area, our governments will buy from them? Thank you.
Thank you very much. I'm just looking for someone who wants to take. Greg, do you want to take that on? And possibly Tokozile?
Okay, as the only non-African on the panel representing an international...
Well, I thought you raised your hand.
Yeah, I did. What I want to say is the following thing that links a couple of things. Very important is strong regulatory framework. That is absolutely key. And I just want to say, it was about 5 years ago, I chaired a European-African a session in the European-African business event we had in Brussels. And the number one issue that came out was strong regulatory systems, ethical distribution systems, fighting counterfeit. And those are three big things that if in Africa you can focus on, it will help not only get innovative companies to do sort of like tech transfer and licensing agreements, but it will also be the foundation for establishing stronger local production.
Excellent, yes. Tokozile, yes.
And probably just to add that even in the discussions that I referred to, on the backdrop of the African Union Summit, there was a lot of discussion around what is government's own contribution, for example, for them to tax better and increase resources that they can put into financing for healthcare so that the burden is not shifted to the private sector. But government has a contribution to financing, which they are already doing, but contributing much more than they are doing. Two, transparency. Important for governments to be more transparent and efficient, as Greg has already said, so that at least corruption is not as rampant as it is in some of the countries in Africa, where then private sector becomes reluctant to engage in the PPPs because they are not sure about how transparent.
Tokozile, you mentioned the C word, and it's so funny because yesterday a number of us were chatting through the session, and it was the elephant in the room. You are the only person to have raised it. I'm not sure whether to applaud you or condemn you. No. But it is what you see. And we're coming toward the end of the session, but I think clearly one or two of you are leaning in. And when you lean in, it means you want to contribute. Amit, did you want to say something?
Yes, I think the private sector will not invest in local manufacturing if the balance is not right. The balance has to be right. If the governments don't create an enabling environment for us, we are not going to spend any dollar putting up factories and manufacturing. Don't make it too difficult. I hear about regulation, and I agree. Quality must not be compromised. But if you make it too tight, you squeeze them out of healthcare, and they'll go into a hotel business.
Excellent. Any final closing thoughts? We're about to finish. Yes, Sarah.
I just really want to make a comment on what Amit also said. We often talk about private sector and we just think of companies that are based outside of the continent and come in to our continent. But we also have private sector African companies. So we have pharmaceutical manufacturing companies that are Kenyan, South African. They actually are based here, and we need to also be conscious of those. They are private companies, but they are our companies. They are local. And we need to be very aware of that, and there needs to be more support from governments to actually support their manufacturing and to rather buy from the local manufacturers. We often talk about buying local when we look at textile industry or food industry, but we need to start doing the same where medicines are concerned.
Excellent. Okay, one final point, Greg, yes?
Very quickly on that thing, most of, or a lot of the imports are obviously from India and China. A lot of these are sort of generic. But bear one thing in mind, India and China have invested a lot in their industry. They're big internal markets. And as in Africa, you need to look also at increasing the regional harmonization in order to help, I think, the industry. And just a comment, I just want to thank the faith groups for the work that they do. And also it's very secure supply chains that they provide, which is very important and something which is industry we value very much.
So, sir, you are blessed. I'm going to bless you, Mr. Faith Group. You're blessed because it's very important to recognize the role you play. So, Greg, thank you very much for that. So that's your panel. That concludes that session. Panel, thank you very much. So, Your Excellency, Deputy Prime Minister, Dr. Amak Thaka, Dr. Rudvizo, we have Greg Perry, Chris Bonnet, Sarah Lambert and Kwesi Bwahene, an excellent panel, a really fantastic session. I'm going to ask you to stay up here for a group photo. But thank you very much to all our delegates, people asking questions. The next session is going to be health security in Africa. I believe that's going to be in this room, is that right? It's going to be here. We'll give people how long break? 20-minute break? 50, hey, cans, c'est tout? 15-minute break, so please, 15-minute break, then back here for health security in Africa, and then lunch and networking from 12:30 or so to 2:30. There are going to be a couple of side events as well in Sala Jonadas 1 and Sala Jonadas 2. One is going to be on good practices for universal health coverage, and the other will be on integrated disease surveillance and response. I'll be taking that one from 1:15 to 2:15, and then in the afternoon, more on health security. But for now, thank you very much. Enjoy the break. Back here in 15 minutes. Thank you.
Please check if your telephone...
Qu'est-ce qui est plus facile? Oui?
Si faut qu'ils viennent parler sur scène, c'est mieux.
Oui,
oui, il n'y a pas de souci.
C'est toujours à gauche.
Oui, allô, Goma est connecté, Goma est connecté.
Brazzaville online. Hello?
Allô, tu es en ligne. On n'a pas le lien WebEx depuis chez vous. We can hear. We don't have the WebEx link. If you want, it's a video. Hello? Yeah, Goma can hear you. But
Brazzaville, we can hear you well. We hear you well in Brazzaville. Sound is okay, but we need a little assistance.
can we have the link for the WebEx?
Brazzaville, we hear you well. We do. We would like to know if we can have the WebEx link. If anyone in the room can assist us, or near the room. The WebEx link. We would like to have the WebEx link so that you can see us. Does anyone have the WebEx link, please?
Okay.
Understood. Thank you.
You can just...
Yes.
How are you in Cabo Verde? Yeah, A10 is with you in Cabo Verde, eh? Not in Brazil.
It's the same order that I sent to you, okay? On the first person is Berouja Alima. Then there's Dr. Maurice Kapkoulé, our survivor. Can you hear me? Then we have Dr. Michelle Yao, Incident Manager Wu. Then we have from the Ministry of Health, Dr. Aouna. Then we have from UNICEF, Incident Manager, Dr. Suleiman Diallo. Excuse me. Then we have from IMC, Country Director, Frigo Patern. Then we have from Ministry of Health, Dr. Luigi, Operations Coordinator. Excuse me, the last name is Minikulu. Sorry about that. And lastly, from the WHO side, we have Dr. Desiree Tambwe, who is our liaison for all our health partners.
Mark, we have Patrick Abok, General Balde, who is in charge of IPC. The room is full, but I'm just going to give 4 names. The room is full. Otherwise, we have General Balde, Patrick Abok, are you able to hear me? I think we will send the list with by email, but I have to send you a sound check. Yes, Etienne.
Welcome in Goma.
to the Swisscom conferencing service. Please. Welcome to the Swisscom conferencing services. Please enter your access code via the telephone keypad to join the conference call. After the following tone, you will be connected to the conference. Other participants have already joined.
Yes, Goma is still connected. Bom dia. Bom dia, Goma. Yes, we do. We can hear you. Oh, ici, on vous entend à partir de Goma. Ah oui.
C'est bon? Bon dia. Mesdames, Messieurs, en vos rangs, grades et qualités, bonjour. Je m'appelle Denise Epeté et j'aurai le plaisir d'assurer la modération de cette session dédiée à la sécurité sanitaire en Afrique, collaboration pour une coordination, une préparation et une sécurité sanitaire mondiale améliorée, avec un focus sur l'épidémie Ebola, une épidémie survenue pour la première fois en 1947 au Congo belge, devenue depuis la République démocratique du Congo, une épidémie qui a connu des vagues cycliques, et concernant l'épidémie qui s'est déclarée en 2018, à la date d'aujourd'hui, le cap des 1000 cas a été franchi, avec un taux de létalité de 63%. L'épicentre de l'épidémie est situé à Katwa, dans l'est de la République démocratique du Congo, dans la région du Nord Kivu. La présente session sera l'occasion d'aborder le règlement sanitaire international lors d'une urgence déclarée, les stratégies pour réduire les risques, la résistance des populations un aspect non négligeable, la gestion de la sécurité dans une zone en conflit. Avant d'écouter les différents acteurs sur le terrain à Goma pour évoquer les difficultés mais également les succès engrangés dans la gestion de l'épidémie Ebola, en guise d'introduction, je vais donner la parole au Dr Joseph Kaboré, directeur de la gestion des programmes du Bureau régional Afrique de l'OMS. Au terme des différentes interventions, nous réserverons du temps pour les questions de la salle et ensuite vous serez invités à vous diriger vers les stands des pays qui vont présenter leurs plans nationaux. Dr Joseph Kaboré, la parole est à vous.
Bonjour, mesdames et messieurs.
Good morning, ladies and gentlemen.
Voilà, il m'a été demandé juste de planter le décor.
I was just asked to set the scene for this session talking about health security, which is a very important topic. But firstly, I would like to begin by saying that I would wish the Cape Verdean women a happy Women's Day, because I have understood that today is Cape Verdean Women's Day.
Voilà, c'est donc avec un très grand plaisir.
So it is a great pleasure for me to address the situation, to set the scene for you. This is such an important issue, global health security, but we will be focusing on certain topics, given that over the next few days we will be looking at very precise, specific topics. The first one is to describe the situation. What is setting the scene as it is today? It's important to note that our continent, Africa, is facing several threats every 2 or 3 years. This is about 150 major events of public concern which we face every year. According to the nature of the disease in question, you know that an outbreak can cost billions of dollars to the countries affected, but in terms of the financial impact, we also have human loss of life. The livelihoods of people are destroyed, and the health systems which are already fragile are completely destroyed or very much decimated. So at the end of the day, human life is what is important. With the changes that are underway, we have noted that some outbreaks and emergencies are affecting our continents in a weightier way all the time. Today, we are seeing outbreaks in areas that were previously unaffected. For example, we have the EVD, we have the Marburg virus, which have emerged in Liberia, in Sierra Leone, in Guinea, in Uganda, and in the DRC. So this is what we need to look at the way forward. We are sure that prevention is of crucial importance here. Yes, if we can prevent outbreaks, if we can detect them, possible public health emergencies, this is how we will be able to respond more quickly and also ensure that we have good health security. Therefore, we are calling on all countries, with the support of other partners, to develop what we call our plans, our national action plans for health security, because each country has a heavy responsibility to ensure the health security of their populations. And the reality is that in our countries, if we consider the 47 countries in the WHO African region, we need to look at the national capacities, which vary from country to country. Generally, most of the countries have major gaps, which is a concern for us. Generally speaking, the main problem is a financial one. However, we do know that most of the capacities in terms of infrastructures as well has to meet the required international health regulations. IHR is very useful. It goes beyond the health security arena, and it contributes to strengthening our health systems. To be more specific in terms of today's topic, many countries in the WHO African region are undertaking plans to deal with disasters or epidemics. These strategies are detailed in their national action plans for health security. We have some stands outside, and I think that 20 or so countries have presented their plans, and we would invite you to visit those stands and contact the delegations involved and discuss this. You also know that WHO is also advocating very strongly for the attainment of universal health coverage, UHC. This morning we had important and useful discussion on this issue. And over the course of this meeting, we will try to see how we can move forward in the best way in order to improve health security in Africa. Across our country, from the preparation stage up to response capacity in case of emergency. Now, in terms of setting the scene, we thought it would be useful for us to connect up with our valiant warriors, our foot soldiers, who can link up with us in this room to assure us that they're doing the work that they need to do. And it's wonderful to be able to exchange with them directly. We will also connect up with our Brazzaville operational centers. The magic of technology enables us here in Praia to connect up with Goma, which is thousands of kilometers away, and also with Brazzaville. It's very difficult, but this is what we need to do to respond to the emergencies and our difficulties that we face on the ground. As you know, the DRC experienced multiple EVDs, Ebola virus disease outbreaks. As has been stated earlier, the first epidemic was in 1976. The current Ebola virus disease in the DRC is the 10th one, and it's the second most EVD outbreak after the West Africa outbreak. Once the Ebola outbreak was declared from March 22nd, more than 1,000 people have contracted this virus, and over 600 of them have died. This is a case fatality rate of 62%. Our colleagues who are on the ground, all our partners, they have a network, but we also are dealing with conflicts on the ground. We are working in challenging conditions. We have to go in armored vehicles to certain areas of the country. As I said to them, it is thanks to them that we are confident that we will conquer this epidemic, this outbreak. I would therefore like to appeal to all of you that we should give ourselves a hand, and that we can also give a round of applause to our valiant fighters. And with these words, I would try to link up to our colleagues, but I think our experts will be able to explain to us how we can use a single microphone to link up with Goma and Brazzaville, and also to respond from the country to the questions from here. Thank you. Thank you, Dr. Joseph Kaboré. We will now link up with Goma to speak with the people on the ground there, and we would like to apologize because of the connection, but because of that we have a video which we will be showing, which will be perhaps easier than the connection live.
The interpreters are trying to hear the video. It is inaudible at present in the booth.
That's impossible.
We apologize, but the sound into the booth is not allowing us to interpret the content.
The interpreters apologize, but it's really impossible to hear what's being said through the link.
Cette coordination est appuyée par les partenaires, parmi les partenaires, c'est d'abord l'OMS pour la coordination. Et nous avons plusieurs commissions. Au total, nous avons 11 commissions qui constituent les...
We don't just have one solution, we have several. I'm trying to pick up what I can. We have our ongoing efforts with the government and with our partners on the ground. We need to have coordination, but also sub-coordination at the sub-national level.
Au niveau central, au niveau provincial et au niveau local. Il y a aussi, à travers la Banque mondiale, il a mobilisé beaucoup de moyens que nous avons et que nous continuons à financer les activités opérationnelles.
The main challenging
The interpreter is going to attempt a summary based on having watched the video earlier. This is an interview with the foot soldiers on the ground, as you heard earlier. It begins with an analysis of the situation, the fight against Ebola, according to the Ministry of Public Health of the DRC. And the question to begin with is, what is the current epidemiological situation in the country? And we are informed by the doctor on the panel that there are 1,019 cases registered up until present, 951 confirmed, 65 probable cases, 637 deaths in total. And that their key activity is, of course, vaccination, and up until present, over 90,000 people have been vaccinated. There are 20 health areas recorded in the country, 20 health areas that have recorded cases of Ebola virus disease. And then we have a question about coordination and are informed that the Ministry of Public Health has been supported by partners, among them the WHO, and that there are 11 committees on the ground dealing with the response effort. The gentleman then says that they are trying to build bridges to create better collaboration between the committees. Then there is a question about the efforts being made by the government, and we are told that there are field personnel on the ground, public health experts from the Public Health Ministry, whose role is to control what is happening on the ground at central, provincial and local level. We've been asked to just wait a bit while they try and improve the technical quality. I will proceed with the summary as I recall it from having watched the video earlier. The World Bank has also mobilized significant resources. There is then a question about what the main challenges faced by the foot soldiers on the ground are. And they say that the disease has emerged in a difficult area where insecurity has prevailed for a number of years. Add to that the fact that there is reticence and resistance which has developed over time at community level. And there is also very high population density in this area of the country, says the speaker. Mobility is also an issue because it makes contact tracing and follow-up difficult, as this allows for the disease to spread more easily. There is also the problem of weak community involvement, which is why they are working to gain the trust of the community, because it is that trust that will allow them to interrupt the spread of the disease.
Je suis désolé, on a des problèmes techniques. On
My
avait pris des
apologies, we
dispositions
have
pour enregistrer.
some technical issues. We made an effort to make a video of the foot soldiers 48 hours ago in Goma, but unfortunately the video sound is not good. I don't know if you can hear the summary that the interpreters made for you. Did you hear the summary? Did you hear the summary that came from the booths? No? So we can perhaps repeat it if you would like. Would you like us to repeat the summary? We can repeat the summary as I recall from watching the video earlier. Okay, so having watched the video earlier, and this is your English booth interpreter attempting a summary, and it will be translated by the Portuguese booth and the French booth. So the summary is as follows. The first question that is asked of the participants in the room, the foot soldiers on the ground, as you heard earlier, is what is the current situation in the DRC in the fight against Ebola? And according to the Ministry of Public Health of the DRC, the epidemiological situation as present is the following. There are 1,019 cases, 951 confirmed, 65 probable, 637 deaths, and of course the key activity is vaccination. And up until the present time, over 90,000 vaccinations, 90,000 people have been vaccinated. There are 20 health areas that have recorded cases of EVD in the country. So this is the overall scenario. Then there is a question about the coordination by the Ministry of Public Health. And the reply by the speaker is that there has been an effort supported by partners, many partners, among them the WHO, and that there are 11 committees that are currently dealing with the response effort. And the indication is that they are trying to build bridges between these committees, and that this is a part of a central coordination effort that also covers sub-coordination efforts. Then another question is asked of what efforts have been made by the government, and the reply is that there is field personnel on the ground, in other words, public health experts from the Public Health Ministry at both central, provincial and local levels. We are also told that the World Bank has mobilized significant resources. A further question is then asked, what are your main challenges? And the reply is that the disease has emerged in a difficult area where there has been insecurity. Insecurity has prevailed for a number of years. Add to that the fact that reticence, resistance have developed at community level. There is also a high population density in this area of the country. And also mobility is an issue because it makes contact tracing and follow-up difficult, as this allows also for the disease to spread more easily. Another problem pointed to is the weak community involvement, which is why the experts on the ground say they are working to gain the trust of the community. Acquiring that trust is what will allow them to interrupt the spread of the disease. Then they turn to the conqueror, that is Dr. Souleymane Diallo, who, sorry, not yet, my apologies, this is the interpreter retracting what I've just said. They turn to Dr. Souleymane Diallo and ask him what the role of the UN has been and what challenges the UN has faced. And the doctor explains that the UN has provided technical, and logistical support, but that the government has remained in the driving seat. They have been leading the operation, and has been that the UN has really just been helping the government. The coordination by the WHO has been something that has also helped them tremendously in their efforts. The WHO has, of course, played a lead role in the coordinating effort, and has provided technical support and coordination. They are also, on the ground, they also have had UNICEF and the WFP. It is also pointed out that UNICEF has worked on in the area of risk communication, community engagement, and IPC. The World Food Programme has given logistical support. MONUSCO has covered logistics and security, and their support covers living and working conditions for people on the ground. OCHA has also aided with coordination. They all work under the umbrella of a joint plan that was drawn up with the support of the government. And this joint plan is actually the framework under which all of the agencies operate. We have to add to that there is this issue that prevails of the lack of trust and also insecurity. These are real constraints that they have been trying to mitigate. The other factor to take into account is funding, according to the speaker. Based on the last statistics available, the speaker indicates that they are at 50% of mobilized resources. The next question is about donors and NGOs on the ground. And the indication is that they have been in the DRC since the very beginning of the fight against the disease, since the outset of the outbreak. There are different pillars of intervention, one of which is management. They have treatment centers provided by EMC, Alima, Samantapans, and others are also engaged in the prevention of infection and sanitation, among them EMC and MEDEL, and also the Medical Corps and Tier Funds. At the level of community engagement in particular, and psychosocial management, also clinical research. In this case, they have Alima, EMS, and MSF. Alima has had strong engagement. With regards to the donors, what they point out is that most NGOs were initially funded by the WHO, and there has been support from DFID and USAID. They point out how grateful they have been for donor support and say that the problem is that what they are seeing now is that most of these donors are facing difficulties on the ground. They are reducing the number of activities, and there's also been a reduction in personnel. They also appeal to the international community. Their appeal is that governments inject the necessary resources for the response to be able to continue. At this point, you can see the gentleman on the screen, they turn to Dr. Maurice Kakoulé, who is the survivor, who gives his first-hand account of surviving the illness, and they ask him how he experienced the disease. Dr. Kakoulé Maurice says that before he had been working as a doctor in Mangina, he had a patient he saw with signs of EVD. He tried to save this woman, but that was how he contracted the illness. And it was at a time when the outbreak had not yet been officially declared. 1 week after admission, he says he developed the same symptoms as the woman he had treated, and he went to the reference hospital in Ouija. The outbreak was subsequently declared. The moderator has interrupted us. It says that, I don't know if you understood, but this was recorded 48 hours ago. It was a brief summary, and we heard Mr. Abedi from the Ministry of Public Health of the DRC in charge of the fight against Ebola. He talked about coordination by the government. He also spoke about the challenges and the efforts made by the government. The first challenge was community resistance and the efforts made thanks to financial resources from partners. Then Suleiman Diallo, who is the incident manager at UNICEF, he spoke for the whole of the UN system, invoking the role played by the UN system in managing this epidemic. Then Rigobert Frater, Gabo, who is the country director, the medical corps. He spoke for the donors and the NGOs in the role they spoke about the role they play in managing EVT. And then finally, Maurice Kakoulé, who was the doctor contaminated right at the beginning by a patient. His wife, too, was contaminated, but thanks to the therapy, their lives were saved. We hope that we are able to connect to Goma, Brazzaville, and Kinshasa via Weblink. If you have any questions, I ask you to please wait for the roving microphone. You will have to be very succinct when asking your questions. Even if it's a comment, please be very concise. We need to speak to Brazzaville, Kinshasa, and Goma, hence the time limitations.
Particulièrement la Guinée, le Libéria.
Guinea, Liberia, and Sierra Leone, after more than 2 years facing this illness, this disease, we had thought that we had extracted a number of lessons from an unprecedented outbreak of the disease in an urban environment, the duration of which was quite lengthy. My question now is, what lessons can we draw from the first outbreak? Because looking at what we're saying today, I'm actually wondering about what really happened in Guinea 4 or 5 years ago. I'm thinking about the death rate, which was very high, the staff on the ground that contracted the illness, and I would like to know what we've learned after 5 years of work being done to fight against the disease. Brazzaville, Goma, Kinshasa, who would like to reply?
Allô? Goma, Brazzaville.
Goma, Brazzaville, Kinshasa. Did you hear the question?
Allô? C'est bon? On a des soucis avec la connexion.
We seem to have some problems with the internet connection, technical hitch. Another question while we wait for them to react and connect. Another question, perhaps? Thank you very much, Denise. Good morning to all the colleagues on the ground in Goma, Dr. Diallo, Michel, Kakule, and Dr. Abedi. Here in Praia, where we have so many questions about the security in the region, all of the restrictions on the ground, all the constraints, and we ask whether the situation has changed. Is it now allowing us to access those who are in remote areas so that we can interrupt the spread of the disease? Because access has been the main problem. Getting the community to accept our action has been another problem. But if we're unable to reach them, if we're unable to speak to them, we can't take those lessons to them. But I think the operation will continue for a long time. The problem, however, is the security issue. And the question is, how far can we go and how long can we wait? Can Goma hear us? Yes, Goma can hear you. If you can hear us, the question was for you, Dr. Abedi. Could you tell us about security in a conflict zone? How do you deal with that? Thank you very much for your question. What I said yesterday is there's a complex epidemic because it is occurring in an area where we have security issues. It is true that there are problems, but we, the response team, have a number of strategies we have developed, the first of which is that we're neutral. We're neutral when it comes to the conflict. Secondly, we have tried to adopt certain strategies. Dialogue with the community is our strategy. We're in touch with them so that we can get them involved and hold them accountable in helping us to fight the illness on the ground. Whenever possible, we talk to the armed groups to try and convey to them the importance of the work we're doing in response to EVD on the ground. We tell them it's a political issue, but we are people working for this to try and bring a solution to help the population. So just in a few words to sum up, that is how we're dealing with the security issue. First question on the lessons to draw from the epidemic outbreak. We know that we had the situation in West Africa. Does the UN want to reply to that question on lessons learned? I can begin. WHO and then Diallo will answer. The lessons learned from West Africa in terms of the current response, we use the anthropologists, sociologists to better understand perception of the risk, allowing us to define appropriate strategies. Second lesson, innovation. The vaccines used for the first time in Guinea are part of the lessons learned. That means we've been able to launch vaccination more quickly now. The outbreak was declared on the 1st of August, and we were able to begin vaccination very quickly, thanks to what we learned in West Africa. That experience has allowed us to act more rapidly, thus giving people a better chance to survive when they contract the disease. I think Dr. Bedi can tell you about the community side of things and prevention. One of the lessons learned from West Africa is the community, how to talk to the community so that they accept our strategy, the strategy we're using. And that dialogue with the community has taken a long time, many weeks. There has been reluctance, but it is ongoing. It creates trust. The experience in West Africa taught us that we might think there are no solutions, but new molecules arose, new strategies, new vaccines arrived on the market, and this has created more trust. Populations believe more in us, so they now know there is a possible solution. We also have to take into account people's food requirements, and we've incorporated all the different lessons in the DRC. We are monitoring the situation closely, and we're giving people greater continuity in care to give them better chances. Can I just add something? Yes, please. The previous outbreaks in the DRC had little emphasis given to transmission. Today, we're more aware of how the disease spreads. We have a subcommittee to be more precise, that also includes people who have been healed. In previous epidemics, we weren't fully aware of all the ways the illness spread, and now we have made progress in comparison with what happened in West Africa. We also have management structures in place. The ones that we use are standard management systems. We are using the best practices acquired. We also have a joint response plan that brings together all the people working on this problem. It's a unique joint plan. There is a coordination mechanism that produces synergies. This coordination has to be efficient if we are to be able to work collaboratively. Question? Let me greet you all. I'm Professor Chernia. I was with you in Abidi in North Kivu, and I'd like to just extend my greetings to you again and give you an eyewitness account of what's happening on the ground. I would like to share our experience with you, tell you of the courage shown by our brave foot soldiers. In West Africa, we learned that it is important to show empathy. This was the case in Guinea, Liberia, etc. Let me also bear witness to the fact that we are working more closely with social sciences, and we're listening to social scientists more, but I think you know that. When I was on the ground, they called me the village expert, and now, you know, the people in the village want to know where the women are. Where are the women? Who are the women leading the response? 60% of cases are women. They are the most affected in Kivu, and yet they are not actively involved in the leadership effort responding to the outbreak. Yes, we talk about techniques, leadership techniques, but that is the crux of the matter. The solution isn't just technique. It isn't just a scientific or technical response. It's social, it's cultural. It requires people to be involved. It requires heart and soul. It requires the participation of women in central roles. So please, please, we need to be more creative. We need to have female leadership in responding to this outbreak too.
Dr. Abedi,
Dr. Abedi?
Dr. Abedi, what can you share with us?
Dr. Abedi?
Dr. Abedi, can you hear me? What is the DRC doing in terms of pushing for women leadership in this initiative, in this combat?
Dr. Abedi devenu muet.
Dr. Abedi, are you there?
Allô, Goma?
Hello, Goma. Calling Goma. Yes, we are facing some communication challenges here. But did you hear the question from Professor Nyang? No, we haven't. Can you report it, please? I will give Professor Nyang the floor again. Please go direct to the question. Straight to the question, please. But first I wanted to bear some personal testimony, but about all the commitment, I am the foot soldier as well. Yeah. Where is the female leadership in this? You talked about the leadership, but you only talked about male. You were talking about technical, but the response to the crisis is not only that. It can't only be scientific. It is also social. It is also cultural. It has to involve gender issues as well. Because most who are affected are women. Women are directly exposed, and the epidemic is really affecting a lot of women and children. They are the ones who are in the front line, and it's difficult for us to get women involved, especially in terms of leadership. So I would say to you, it is up to you now to look to the issue of female leadership.
Allô?
Yes, you're hearing us, but we're now waiting for your response to the question from where are the women in all this? We do have women involved in the coordination efforts in Goma. We have about 40% of our teams comprising women. The fact of working with the community, in fact, most of our community contact is through women, and most of the teams on the ground we're doctors as well as women. We also are working with anthropologists on the ground, and we know that this affects the perception of the situation on the ground. I give the floor back to you, Dr. Abedi. It's the women talking to you. 40% is not gender balance. It's not complete parity. You need more women involved. Any other questions from the room?
No.
Perhaps one? Thank you, Dr. Nyang, not Professor Nyang. And I come from Mauritania. I would also like to thank you, but also like to say that there are some of our colleagues who are working on the ground in Beni and in Mutango. I am representing a doctor who was there working on the ground, and I would really like to congratulate you for this. But how does the coordination work between you and those who work on the ground? My second is a question for clarification. the term of incident manager, I think it was invented perhaps by WHO. We have Dr. Souleymane Diallo, who is an incident manager of UNICEF. We have Michelle Yeoh, who is an incident manager for WHO. So how are the responsibilities divided? You have social aspects focused by one organization, but how do you coordinate amongst yourselves at the level of UN agencies involved? Thank you. Goma, can you respond, please? I think the person was very far away from us who asked the question, and we didn't quite hear. It was a bit inaudible for us. Sorry. We need a short question. My short question, in a nutshell, is the coordination between you and Dr. Souleymane Diallo. Because you have different incident managers, you need to have responsibilities well established as what's happening on the ground. How are this divided? Because we really need to deal with this, because in principle it should be WHO as the lead, and then also with CDC. But then what is your contact with the people who are on the ground? I would like... we have Dr. Danica, who has been with us since June, who has been with you in Beni and in Butango.
Allô, Goma, vous avez compris la question?
Goma, did you understand? No? If we've understood, you want to know what are the coordination mechanisms between WHO, UNICEF, and so on the ground. If that was the question, then I would simply say that the lead is indeed assured by WHO, and they have that mandate in the area of health. All the other stakeholders or agencies who work with us in this combat, in the struggle we have, we work through a coordination mechanism, but it is directed by the government. And we try to see how we can best coordinate our efforts, and we try also to involve NGOs and our other partners and our donors. In terms of direct contact with personnel on the ground, we have tried to learn lessons from past experiences. UNICEF has expertise in hygiene, sanitation. WHO has expertise in terms of responding, and we have them having the leadership role, also in terms of surveillance and response. But everything actually is under the leadership of the government. This mechanism that we have works very well, and to date we haven't really had too much problems with it. Thank you. This isn't a question, but a contribution. We wanted a question about how we dealt with the situation in Guinea, the response. Thank you very much. I wanted to respond to Dr. Nyangsame to say that we have really learned a lot from West Africa. If we hadn't applied the lessons learned, the situation would have been far worse today. The proof is that if we look at the crisis in the Equator, it was very restricted, but we learned a lot from it in West Africa. We used Guinean vaccinators, and I would really like to congratulate that team. That vaccination helped us to increase the number of survivors. Everybody knows about that. We have never had so many survivors before since we had an outbreak of Ebola. At the same time, I think that contexts are different. We have said that this is the first time that colleagues are going about in armored vehicles in order to have access to certain areas, because there are some areas that are clearly at risk of people being killed. But together, and as Professor said before, we need to be creative. What can we do to have access to all these areas? This is very important. The contexts differ across the board. We have seen Dr. Moeti, the Director General. I think they have actually visited those sites. Even if you look at the African Union, they are also involved. We're not only looking at the technical aspects, we are also, and above all, looking at the security situation and also looking at community participation so that we can mitigate the effects and all the problems. The issue of female leaderships, I think this is a very good track to follow. But we really have benefited from lessons learned from West Africa, where it was catastrophic before, and it would continue to be like that if we hadn't learned those lessons. And thank you. Thank you, Dr. Kabore. I would also like to say thank you to the people on the ground in Goma, in Brazzaville. Even if they couldn't quite hear us, we also had a link up with Kinshasa. Thank you very much to Dr. Abedi. I think I found Dr. Maurice Kakule, Miangabo, and Dr. Suleiman Diallo. Some practical information before we leave each other. I invite you to visit the country stands because there you will see the national action plans. I would also like to point out that there is another parallel event between 1345 and 1545 on the best practices of Cape Verde in terms of UHS. And finally, we have the final communication of the WHO, which will be available when you leave this room. You are invited to take a copy and to make your comments and then to give them back to the hostesses who are dressed in black and yellow. And please do that before 10 a.m. tomorrow. And in conclusion, I would be happy to see you back at the beginning of the afternoon about 2:30 to have a session dedicated to health, security, opportunities and challenges. Thank you very much and bon appétit.
With some challenges, but
oui, mais c'était.
At one time, Goma was cut off.
Thank you, miss. Oui, c'était.
Congratulations, ça c'était difficile.
Ah bah oui, c'était pas facile, hein.
Super. En tout cas, congratulations. Yes, thank you.